Very good morning to all of you, and thanks to organizing team for this opportunity. I'm going to talk on the esophageal replacement by gastric tube, and lot of problem has been described related to esophageal replacement by gastric tube, but we'll try to summarize how to reduce the mortality and morbidity in these cases. As you know, the most common indication for esophageal replacement is long gap esophageal atresia, and which is defined as difference between the upper and lower pouch is more than 3 centimeter after mobilization, or more than 2 vertebral body difference where primary anastomosis is not possible. We know the classification most common is type C followed by type A. Most of the type C, the primary anastomosis is possible, but when there is a long gap esophageal atresia, then there is an option for esophageal lengthening, and various technique had been described like Kimura techniques, Fokers, multiple seromyotomy, delayed primary repair, then mobilization of flap from the upper pouch, so on. If this fail, then primary treatment is esophagostomy and gastrostomy, and the second stage comes for the esophageal replacement. There are many options which has been described like gastric pull-up, gastric tube, either isoperistaltic or antiperistaltic, colon either left side or right side, and the jejunal loop. And every procedure is associated with their own complications. So I'm not going detail about the various technique, but I'm discussing our experience in the gastric tube. We have treated 27 patients so far with a 12-year duration, and most common cases were pure esophageal atresia, and the second were long gap esophageal atresia with tracheoesophageal fistula. The stages was that in first stage as life-saving, and in second stage I am doing isoperistaltic gastric tube, retroesternal route, and making ostomy in the neck along with feeding jejunostomy. So I am not doing the primary anastomosis in the neck, which is the culprit for the leak and the stricture formation. In the third stage, after 4 to 6 weeks, we are doing the ostomy closure in the neck like colostomy closure as usual. So preoperative preparation, the preoperative preparation is same like other cases, but most important thing is that you should know the capacity of the stomach because you are reconstructing the tube from the stomach. Then brief about the surgical procedure, supine position, midline incision, stomach is mobilized along the greater curvature while ligating the short gastric and left gastroepiploic vessel and maintaining the vascular arcade of gastroepiploic. So mainly right gastroepiploic vessel is the main which supply. And then same times we are mobilizing the duodenum, and then we apply 20 to 24 number of tube and the along the greater curvature, and the gastric tube is created by using the stapler. Then it is measured from the GP sternum to the mid of the neck, and then retroesternal tunnel is created, and then this tube is brought through the retroesternal into the neck, and ostomy is created along with feeding jejunostomy. And feeding jejunostomy we start after 48 to 72 hours, and gastrostomy to be put for the decompression as well as for the feeding point of view. And total 27 patient, 25% completed all stage of surgery. The mean age of surgery was 8.5 months, and mean weight was second surgery 9.5 kg. And duration of surgery in the second stage was 90 minutes, while in third stage was 35 minutes. Some of the complications which we have faced in follow-up, no patient require ventilatory support. That is the good thing, and that's why I started this technique. And the cervical leak was present in 3 cases that was managed conservatively. Esophageal stenosis was present in 1 patient that was managed by simple dilatation. Nuclear scan was done in 15 cases, that 4 cases show the reflux, and there was a 1 mortality in the follow-up patient. That patient develops due to severe respiratory distress. This is the follow-up patient showing good-looking esophagogram. And this is the endoscopic view. You can see the wide anastomosis side, and the gastric tube is well looking. and the assessment of the weight of this patient were 50th percentile of the according to WHO growth chart weight for age, and height according to the WHO height for age, and nutritional status, especially hemoglobin, serum protein, and albumin were within normal limit. So on conclusion, I would say that three-stage surgery for esophageal replacement by gastric tube may prevent leak and subsequent complications, short operative time, less surgical trauma, and better result. There is a limited need for post-operative ventilatory support. Growth and development is close to near normal. Thank you very much for patience hearing.